Good evening and welcome everyone to the DOS Postgraduate Education Program, DOS-PEP as we all call it. And as you all know, we are currently in the third module, that is the Strabismus and Neuro-Ophthalmology. And today is the sixth class of Strabismus module, and we are on the 51st lecture of DOS-PEP. In the last class, we covered exodeviations, and today we have an esteemed speaker, Dr. Amrita Sindhu, who will be talking about exodeviations. We have with us our moderators for the session, Dr. Gunjan Saluja and Dr. Anita Gangar ma'am. And Dr. Amrita Sindhu, who is the speaker for today, is a consultant pediatric ophthalmology and peds neuro-ophthalmology, strabismus and adult cataract services at Arvind Eye Hospital, Coimbatore, Tamil Nadu. She's also a certified NABH assessor. And before we move on to the talk, we have our Secretary of DOS, Dr. Praful Marana, sir. Sir, would you like
Thank
to
you,
say a few words?
Pranita, and thank you, Dr. Amrita, for accepting our invitation. And I'm extremely sorry for that little error on our part.
It's
And
totally fine, sir.
since you said your resident will be joining, and also there is a dramatic increase in the number of residents that are enrolled in this PEP group, so I'll take just 1 minute to explain you and others about what we are actually trying in this PEP. So this postgraduate education program is an initiative by DOS, and what we are trying to do is we are trying to provide good quality lectures to all PGs like MS, DNB, diploma, who doesn't have good access to good quality teaching classes. So this is free to all the students. They can join by using the link that we keep on sharing every time we have a lecture here. And from this onwards, we have started a trend, Dr. Amrita, that after the lecture is over, we'll be sending the PDF of the PPTs, not the PPTs, to the students. So I hope you are okay with that, so that they can revise whenever they feel like.
Yes,
So,
sir. Sure.
so with this, and also I request Dr. Amrita, please try to take as much as students into this group, and you can join our team, because we need good quality teachers to be on our panel so that we can make it a big PP platform. And with
Sure.
this, the stage is yours. You please start your lecture. And thank you,
Yes.
everyone.
So thank you, Dr. Pranita. Thank you, Dr. Prafula, sir, for having me here. Thank you for DOS team. So I'm really glad to be on this platform, which has, I think, the maximum number of students joining in this group. I heard that it's around 1,200 to 1,300 students joining. Really glad to talk to all of them. Because squint is one such topic which is not really exposed to everybody. Not everybody has an access to learn squint or to practically know about the squint. So for those students, I think definitely this will be a very useful talk. So let me share my screen. So is my slides visible?
Yes, ma'am.
Yeah, okay. So today I'll be talking about exodeviations. So I hope the exodeviations was previously discussed. So today
Yes,
I'll
ma'am.
try to I'll try to cover the entire topic of exodeviations, because it is quite important in point of exams, because most of the cases what they get as a in the exams, especially practical exams, most commonly includes exodeviation. So a detailed and thorough knowledge about exodeviations is very important for the postgraduates. So to define exodeviation, it is outward misalignment of one eye as compared to the other eye. So you can see here, the right eye is straight and the left eye is deviated outwards. So this is called exodeviation. So here it is a tropia, exotropia. So you, what do you mean by tropia? It is a manifest deviation. You can see a manifesting left eye deviation. So here you can call it as exotropia. So broadly, we can classify exodeviations as concomitant deviations and incomitant exodeviations. In the concomitant exodeviations, we have primary exotropias and secondary exotropias. In the primary exodeviations, we can further divide it into infantile exotropias and intermittent exotropias. In the secondary exodeviations, we have sensory exotropias, consecutive exotropias, and an added one is a residual exotropia. These are all the secondary exodeviations. In the incomitant deviation, we have a paralytic exodeviation, restrictive exotropias, musculofacial anomalies, which the main important one among them is the Duane syndrome, and the dissociated horizontal deviation. So each one of these topics I'll be explaining in detail regarding their presentation, the clinical features, and briefly the management of these conditions. So before moving on to the classification, let's first know what is exophoria. So you can recall that, as I previously told, tropia means a manifest deviation, whereas phoria is opposite of that. That is, it is a latent deviation. So exophoria means it is a latent exodeviation. So here, the normal, when you shine a torch, you will see that the light reflex falls at the center of each pupil in both eyes. But when you cover one eye, under the cover, you can see that one eye is drifting outwards. So that is when the fusion is broken. So when you cover one eye, the fusion breaks, then you will see a small amount of exodeviation. But the moment you remove the cover, you see that the eyes become straight again. So this is called as exophoria. So exophoria is a latent deviation, and this is quite common in almost 80 to 90% of the normal population. All of us have exophoria. It is not manifested as such. Only under the cover, when the fusion is disrupted, you will see the deviation, and it is mostly asymptomatic. You don't have to really treat exophoria. Most of us have it. So there is also a term called as pseudo-exotropia. As you saw, there is a true exotropia. There is something called as pseudo-exotropia, which is not a real deviation. Here you can see the picture of this child. It looks as if the child is having a left exotropia. But carefully you observe that at the light reflex is almost at the center of the pupil. So it is an apparent deviation. So eyes are actually aligned and you don't see any movement or deviation on cover test, but it appears to have an exotropic position. So why does this happen? This can happen especially in patients or children who have a wider interpupillary distance, or what we call it as positive angle kappa. So you should remember what is this positive angle kappa. So angle kappa is an angle formed between the pupillary axis and the visual axis. So pupillary axis, the visual axis is the line joining the fovea to the point where the object is fixated. So that is a line of sight. One more is the line which is passing through the center of the pupil. So the angle formed between these two lines is called as angle kappa. So angle kappa is normally it is around 5 degrees for a normal adult. Anything more than 5 degrees, we call it as positive angle kappa. So this positive angle kappa will give an apparent exotropic position, so exotropic picture, whereas a negative angle kappa will give a pseudo esotropia picture. So most of the time, this positive angle kappa is seen as seen in isolation, not related to any other disorder. But rarely, it can also be associated with some retinal pathologies, especially dragging of macula, which is seen in retinopathy of prematurity, and any macular scars or high myopia. In these conditions, because of the dragged macula, so patient will have an apparent exotropic fixation. So this is called as pseudo-exotropia. So now let's move on to the classification proper. So the first I said it's the primary exodeviations. In that, let's talk about infantile exotropia. Infantile exotropia, as you recall, you would have learned in infantile esotropia. This is any exotropia which presents before the 6 months of age of the child. So usually that is called as infantile exotropia. So you know that infantile esotropia is quite common. So infantile exotropia is less common than that of the infantile esotropia. So the clinical features are mostly it is of a large angle, presenting at about 30 to 40 prism diopters. Mostly it is alternating. You will see the child fixating with either eye when you're examining. But since the child is seeing through one eye, they don't have binocular single vision. So the lack of binocularity is a feature of this infantile exotropia. So since the child is alternating between either eye, amblyopia is less common. And also, one more important thing you have to remember is first few months of life, the child can have apparent outward deviation of the eye before they develop the visual fixation, which is physiological. You can't consider that as an infantile exotropia. It is a constant deviation which is seen between 4 to 6 months of age. So initial physiological outward deviation is normal. We don't have to really treat that. So one thing you have to always keep in mind, the essential infantile esotropia is a condition where there is no underlying pathology. The child usually has just an exotropia, and most commonly there can be a positive family history. If you observe the parent, either father or mother might be having an outward deviation, but the more common one is these exotropias are commonly associated with some kind of developmental delay, like this child who is having a craniofacial abnormality, like a Cruzon syndrome, where you can see shallow orbits causing a pseudo proptosis with an outward deviation, exotropia. So whenever you see a child with a exotropia, so always search for underlying neurological abnormalities. That is because that is the more common association. So you should look for any craniofacial abnormalities, any syndromic association, whether there is any developmental delay, like a child with a cerebral palsy or any other developmental disorders. So you should always rule out this, especially when you're taking a case of exotropia. Try to look for these conditions during your systemic evaluation. So all this essential infantile exotropias and these conditions have some associated features which you would have already learned in esotropia as well. That is the V pattern or an A pattern. These are the pattern strabismus, as well as the other associations are dissociated vertical deviation and inferior oblique overaction. I have tried to explain this with the help of a picture here. You can see in the middle picture, you can see that the right eye is exotropic. When the patient looks down, you can see that the exotropia is reducing. But when the patient tries to look up, you can see the angle of deviation is increasing. The exotropia is increasing. This is called as V pattern. V pattern is when in up gaze, the exotropia increases, and in the down gaze, the exotropia decreases. So usually these patterns are associated with oblique overaction, not all the time, most of the time. And here you can see there is an inferior oblique overaction. When the patient is trying to look sideways, the adducting eye is being deviated upwards. As you see in this arrow, you can see that there is an inferior oblique overaction in both the eyes. So in the same way, there can be an A pattern also. A pattern is when the deviation is less in up gaze and the exodeviation increases on down gaze. That is called as A pattern. So V pattern is more common as compared to that of A pattern. So this pattern can be associated with inferior oblique overaction, or can happen even without inferior oblique overaction. That is mostly because of the displacement of the horizontal recti muscles. So you have to remember 3 common associations with exotropia, that is A and V patterns, dissociated vertical deviation, and oblique overactions. So it can be inferior oblique or superior oblique overactions. So moving on to management, it is always preferred to do an early surgery. The earlier we align the eyes, better is the restoration of the binocular single vision. So usually we prefer to operate as early as 9 months to 1 year of age, or ideally within 1.5 to 2 years of age, we should plan to align their eyes. The earlier alignment, usually the binocular single vision is regained easily, and child can also develop stereopsis subsequently. So the preferred surgery of choice is either a bilateral lateral rectus recession in case of smaller or moderate angles, or you can go for a unilateral recess resect procedure, especially when the angle is very large, when you feel that bilateral lateral rectus recession may not correct the deviation fully. In that case, you can go one eye at a time. So you can recess and resect one eye followed by the other eye. So in this way, you can correct a larger deviations. So if you notice an associated A or a V pattern, look for any association of inferior oblique or a superior oblique overaction. So you can combine this oblique weakening procedures along with the horizontal recess resect procedure. Or if there is no inferior oblique overaction, then you can do a displacement of the horizontal recti muscle. So that is how we manage the essential or an infantile exotropia. So let's move to the next, the most important topic, that is the intermittent exotropia. Intermittent exotropia is the most common type of exotropia. So, and this is the most favorite questions which is asked both in theory as well as in practical examination. So you should know in detail about the topic, the details of this intermittent exotropia. As the name suggests, it is an intermittent exodeviation. So you can see in this picture, the child looks absolutely orthophoric. You don't see any deviation in the first picture. I try to cover one eye and I remove the cover. You can see that the left eye is deviated outwards. So that is when the fusion is disrupted, you can see a deviation being manifested. This is called as intermittent exotropia. So the clinical features of intermittent exotropia is that usually the parents present the child with an intermittent outward deviation of the eye, especially when the child looks at a long distance, when the child is very tired or sleepy, or when the child is ill. So that is when the deviation becomes manifesting. So especially, basically, it is when the fusion is disrupted, when the child can no longer hold the fusion for a longer time, that leads to deviation of the eye. And constant outward deviation can lead to asthenopic features like tiredness, soreness of eyes, a headache, and all those symptoms can be a presenting feature. And sometimes when the fusion is briefly disrupted, they can also present with transient diplopias, intermittent diplopia, that is also called as decompensated exotropias. So they can no longer fuse the images, leading to double vision or a diplopia. There is one common the condition which is called as diplophotophobia, which is quite commonly associated with this intermittent exotropias. This is a condition when the child is exposed to bright light, like when the child goes out to bright light, suddenly child complains of severe photophobia, unable to open both the eyes, and tries to shut one eye. This is because when the child is exposed to bright light, that causes dazzling of the retina. When the retina is dazzled, there is disruption of fusion. So this causes the eye to deviate outwards, causing both diplopia as well as photophobia. So many of the kids are brought with this complaint. The child is not opening the eye when it goes to bright light. So that is also a common presenting feature. And one more uncommon presentation is called micropsia. Micropsia, the image appearing smaller, is called as micropsia. So whenever the child tries to accommodate, so to control the fusion, so because of the accommodation, there is minification of image. This gives an impression of object appearing smaller than what it is really. So that is called as micropsia. Micropsia is also an uncommon clinical feature which we see in intermittent exotropias. Let's move on to classification. There are two main classifications which you have to remember. So this classification is basically planned on the amount of deviation. So basically you have to measure the deviation for near, using a near target, and then measure the deviation for distance at around 6 meters. Then you compare both the deviations. It is called basic type of intermittent exotropia when the difference between the near deviation and the distance deviation is less than 10 prism diopter, which we commonly see. So commonly when you measure any deviations for that matter, a difference of 5 to 10 prism is common. So in that case, we call it as basic type. So basically we can say near and distance are almost equal. We call it as convergence insufficiency type when the near deviation is more than distance deviation. That is more than 10 prism diopters of difference between near and distance. Near being more is called as convergence insufficiency type. And there is something called as true divergence excess type and pseudo divergence. I'll explain it later on. True divergence is something where the distance deviation is more than that of the near deviation. So the deviation being more than 10 prism diopters. There's a condition called a pseudo divergence excess type. So it looks like that the divergence is more for distance than at near, but after a prolonged patching of one eye, it becomes a basic type. So that is called as pseudo divergence excess type. So why does this happen? This pseudo divergence is because at near they try to use the convergence. So because of the convergence, they don't deviate much. So because of that, it looks like as if the near deviation is less. When you do a prolonged monocular patching, which is also called as patch test, which I'll show you with a video how it is done. When you patch one eye for more than half an hour to 45 minutes, the fusion is completely disrupted. That is when you get the maximum amount of deviation. So that is called a pseudo divergence excess type. So this is one classification. Sorry, I have written as Brian's. It is Burian's classification. Then the other one is the Kushner's classification. Kushner's is also almost similar to that of Burian's, but here we take into account what is called as AC by A ratio. So AC by A ratio is nothing but the ratio which is between the accommodation. Normally for the one diopter of accommodation, there is certain degree of convergence that has to happen. When this the ratio exceeds, when normal AC by A ratio is up to 4 to 6, anything more than 6 we call it as high AC by A ratio. So here in Kushner's classification, they are basically taking into account this AC by A ratio. So you should recall that how the AC by A ratio is measured. Usually it is done by a lens gradient method, which is commonly done using a lens in front of the eye. You can measure the near deviation, put a +3 diopters lens, and again do the measurement. The difference between the measurement between without the lens and with the lens divided by the power of the lens will give the AC by A ratio. So usually basic type here in Kushner's classification, it is distance and near measurements are equal. That is same as that of the previous classification. There is a condition called as tenacious proximal fusion. Here it is nothing but similar to pseudo divergence excess type. So here basically it seems to be more for distance, but on monocular occlusion it becomes basic type. High AC by A ratio is that even after prolonged patching for 60 minutes, there is a disparity in near and distance. So distance measurement is more than that of the near measurement. And the proximal convergence type is the distant measurements exceeds near measurement, but AC by A ratio is normal. Whereas low AC by ratio is when the AC by A ratio is lower. And the fusional convergence insufficiency type is when the patient has very poor convergence that leads to near measurement being more than that of the distance measurement. So this is a little bit more complicated classification, but this classification helps us to decide on the type of surgery to be done. So because when you're planning to operate and get more correction for distance, you have to do more surgery on lateral rectus. Whereas when you find a convergence insufficiency type, that is, we have to operate more on the medial rectus. So this Kushner's classification helps us to decide basically on the surgery type. So basically when you're assessing the intermittent exotropia, we grade the intermittent exotropia into 3 types based on how well the fusion is controlled. So see this first picture. So on covering the eye, you can see a deviation happening. But the moment I remove, the eye just briskly comes and becomes orthophoric. This is of good control. So the moment you cover the eye briskly takes a fixation. That is called as good control. Whereas here, if you see the second video, you can see there is some amount of strain when the child tries to fuse. Either most commonly it happens after a blink. So child tries to blink and then brings up the comes to the primary position. That is called as fair control. And here you can see the eye is orthophoric. You can see the eyes are straight. And just see, as I cover one eye, you can see both eye taking an exodeviation, and I remove the cover, but still the eye remains in an exotropic position. You can see it again. So you can see eyes are orthophoric. I'm doing an alternate cover test. I alternately cover either eye to disrupt the fusion, and I remove the cover, the eye remains in an exotropic position. This is called as poor control of intermittent exotropia. This is how we clinically grade the intermittent exotropias. So there is one more way of evaluating the intermittent exotropia, that is called as Newcastle scoring system. So in this, we take into account home control and clinical control. Home control is you have to explain the parents to see how often the child is deviating, and they have to note it down in a book and come back. So you score it as 0 when there is no deviation at all. A score of 1 is given when the child occasionally deviates for distance, that is less than 50% of waking hours. A score of 2 is given when more than 50% of the child, more than 50% of the time the child squints for distance. And a score of 3 is given when the squint is seen even for near. So that is the home control. Clinical control, as I told it, as I already explained, you see for good control, fair control, or poor control, both for distance as well as near. So when you add the home control with the clinic control, that gives the Newcastle scoring. So any score above 3 needs treatment. So treatment it means any kind of non-surgical treatment should be started above 3. Any score going above 7 indicates surgery. So we have to plan for surgery. This is one way of evaluating the intermittent exotropia. So if you see a child with intermittent exotropia, these are the tests which you have to do. So one is the distant stereo acuity. There is near stereo acuity. Then you have to measure the angle of deviation. Since these are all concomitant deviation, the common measurements what we do is measurement of deviation for distance. That is when the child asks the child to read a Snellen's chart and do a cover test, and a near deviation where you use a near target and try to do the measurement of the deviation. So that is what you have to do. Then I told we have to do a patch test. Patch test is very important in case of this intermittent exotropia. The idea of doing patch test is to disrupt the fusion completely. Only when you disrupt the fusion completely, that is when you get the maximum amount of deviation. So I already explained you how an AC by A ratio is measured. And there is something called as far distance measurement, which has to be done in these cases. Far distance measurement is nothing but you make the patient sit in a long hallway, probably more than 10 or 20 meters distance. Ask the patient to fixate at an object which is at a very far distance, let's say around 20 meters. That is when their convergence is that the fusion is totally disrupted and you get the maximum amount of deviation. So this patch test is basically very important to rule out this pseudo divergence excess or a tenacious proximal fusion. So let's see how a patch test is done. Here, this patient, I applied a patch on her left eye for about 30 to 45 minutes. Now I'm going to do a patch test. So ask the patient to keep the eye closed before opening the patch test. You have to explain that. Then I cover one eye and only then I remove the patch. This is because I don't want both the eyes to be open at a time. So all the time during doing this test, I keep one eye closed. So here I keep a base in prism because I'm measuring an exotropia, and I ask the patient to read the Snellen's chart. And then you do a prism cover test. So every point of time, make sure that you are not keeping both eyes open. So I'm keeping one eye occluded even while changing the prisms. I do the alternate prism cover test. and I'm trying to get the amount of deviation. Okay, so the basic idea here is not to allow the patient to fuse at any point of time while doing the test. So by doing this patch test, you can actually measure the maximum amount of deviation. So the idea of prolonged patch is to break the fusion. So we all know that we have a lot of tests for near stereo acuity. The most common and the standard one which we use is a TNO test. But knowing about distance stereo acuity test is important, especially in case of intermittent exotropias, because in case of intermittent exotropia, the stereo acuity which is lost initially is the distance stereo acuity. Only then the near stereo acuity is lost. For a doctor or for a clinician, it is ideal, or it is good to pick up the patient early, because when we can once the distance stereo acuity is lost, that is an indication that the child or the patient is going for a suppression, or the deviation is increasing, and that becomes one of the indication for surgical correction. So the two commonly used distance stereo acuity tests are Randot stereogram and Frisbee-Davis distance stereo acuity test. Both these tests are done at a distance of 3 meters. So most of the other tests what we use assess the stereopsis only for near. So only in case of intermittent exotropia, it is important to assess the distance stereo acuity, because that is the first to be lost. So moving on to management of intermittent exotropia. So any squint for that matter, the first and foremost thing is to correct the refractive error. Commonly in the clinic, what we see is the myopias or uncorrected myopias are usually associated with this intermittent exotropia. So always do a cycloplegic refraction, give them the best corrective glasses. Once their vision improves, their fusion will also improve. That will improve their control of intermittent exotropia. So the first step in management will be the refractive error correction. So always do a cycloplegic refraction. If it is a good control or a very small deviation, so you can put them on some fusional exercises. Fusional exercises can be any type of cards which we use for, like a CAT card or a DOT card, which can be used for distance improvement of distance fusion. You can use a Brockstring exercises. These are all the orthoptic exercise. And also we have newer software-based exercises which can actually improve the fusional reserves and can improve the stereopsis as well. So of late, we are also giving lot of software-based exercises. There is something called as over-correcting minus lens therapy. This is also a non-surgical way of treating this IXTs. The idea behind this therapy is that you should remember that minus lenses or the concave lenses stimulates convergence. So when it stimulates convergence, you know that the exotropia is reducing. So when you give an over-correcting minus lens, that is, you correct the child with a -2 to -3 or -4 diopters of spherical lens, make sure that it is not disrupting their vision too much. So when they wear those glasses, even without a refractive error, that can stimulate their convergence and help to improve the control. This is called as over minus therapies. This is also one way of treating intermittent exotropia, especially when the angle is very small or the child is too young to get a proper prism cover test, and to decide when we are not sure about how much deviation or not sure about the surgical correction. This helps us to improve the control as well as postpone the surgery. So that is where the overcorrecting minus lens comes into play. The other way is use of prisms. So we can give a small basin prisms to control the deviation. So let's see when we have to do a surgical management. So indications for surgery, as I already told, if the patient is developing suppression, that is, they are using only one of their eye and the binocular vision is lost, that is an indication for surgery. Once the binocular vision is lost, we know that the stereopsis is going to drop. That is also an indication for surgery. Clinically, when you see a poor control of intermittent exotropia, that is an indication for surgery. very frequent outward deviation, as you see in the Newcastle scoring system. If you see a frequent outward deviation, and in case if it is a very large angle measuring about 40 or more than that, and lastly, for a cosmetic indication, we can do a surgical management. So the surgery, ideally, since it is an concomitant strabismus, we should try to do a balanced surgery between both eyes. So bilateral lateral rectus recession is planned. So that is an ideal way of correcting the intermittent exotropias. Sometimes when it is, in case if the child has an amblyopic eye, one of the eye is amblyopic, or when there is a dominance of one eye, we try to do the squint surgery on a non-dominant eye. So in that case, we do a unilateral resect procedure. So if we go back to Kushner's classification, when you see a divergence excess type of intermittent exotropia, we can plan for a bilateral lateral rectus recession. Whereas in case of convergence insufficiency type, you can either go for a unilateral resect, or you can go for a bilateral medial rectus resections. So that is how we treat surgery. So the amount of deviation that has to be corrected, usually either we can plan for an orthophoria, or very young children, we can try to do them slightly esophoric. By then, over time, this esophoria will become orthophoria. So that is the aim of surgery. Let's move on to the secondary exotropias. As I already told, there is a condition called as sensory exotropia. Sensory exotropia is the deviation which is occurring due to disruption of sensory fusion, which can happen due to loss or severe reduction of visual acuity in one or both eyes. So common causes are any anisometropia causing amblyopia in one eye, cataract which is long standing. You can see small children, congenital or developmental cataract children, usually they have an associated deviation. So that is commonly called as sensory deviations, or any long standing corneal opacities, or any underlying retinal pathology. Basically, any condition which can disrupt vision in one eye can lead to sensory deviation. So you would have already heard about sensory esotropias. So the common notion is that when the child loses vision at a very early age, it is seen that they develop esotropia, which is called as sensory esotropia. When a child develops vision little later in the age, usually it is sensory exotropia, but this is not a hard and fast rule. It can vary due to various factors. Even a small younger child can develop an exotropia, but this is what we commonly see. Here in this picture, you can see an older kid having a cataract in right eye associated with a sensory exotropia. So other factors which can contribute for this esotropia or exotropia is the refractive status of the eye and various other factors. So surgical management, you have to remember, is only for the cosmetic purpose we do a surgical correction. So you have to clearly explain the patient before doing surgery that the vision is not going to recover in these conditions. It is mainly for cosmesis, and the chances of recurrence is common in these sensory exotropias. So let's move on to the next secondary type of exodeviation, that is the consecutive exotropia. Consecutive, as the name suggests, previously a esodeviation, now turning into an exodeviation, is called as consecutive exotropia. This can happen either because of a surgery where there is overcorrection which has happened, or it can happen over time. As the eye grows, there can be displacement of the muscles. As the eye grows, there can be a slipped medial rectus muscle or a stretched scar which is causing outward deviation of the eye. So it can rarely happen even without any surgery being done previously. So initially the patient can have a small angle of esotropia or an intermittent esotropia. As the child grows, you will see it is going into an exodeviation. This is called as consecutive exotropia. So the clues to identify what is consecutive exotropia is, one is you have to ask for the any previous photographs of the child. So any childhood photograph, you will see that the child is having an exodeviation, and they'll give a history of squint surgery being done, and now the child is presenting with an exodeviation. So that is called as family album tomogram. So that is what you have to look for the old photographs. And also rarely you can see a surgical scar. If you carefully look with a torch or a slit lamp, you can see a small surgical scar which gives an idea of where exactly the incision is made, and the conjunctival scars can give a clue on the previous surgeries if they don't have any proper previous history. So this consecutive can happen immediate post-op when the intended deviation is more than what it is actually calculated, or it can happen various years, as I already explained. That is called as consecutive exotropia. So what is residual exotropia? Residual is when, here you can see in this picture, the child presented with a large angle deviation. We have done a surgery in one eye, and you can see even a small amount of exodeviation still persisting. So this is called as residual deviation, residual exotropia. So large angle exotropia, do a surgery and still some amount of exotropia remaining, then it is called as residual exotropia. So you should know the difference between a consecutive exotropia and a residual exotropia. So that is all about the concomitant deviations. Now let's move on to the incomitant deviation. So as you recall, so incomitant deviation is a condition where the ocular deviation is different in different gaze positions. So the incomitance or the amount of deviation is more in the field of action of the muscle involved. So along with that, incomitant deviations also have limitation of movement in the field of action of the muscle. And you should know there is a difference in primary deviation as well as the secondary deviation. So you should remember that in concomitant deviation, you don't see any limitation of movement of the extraocular muscles, and usually the primary deviation and the secondary deviation is equal. So exam point of view, it is very important to know the difference between concomitant and incomitant deviation. Most of the books gives the table explaining these two. So it is a very favorite and commonly asked question. Broadly, we can classify incomitant deviation into paralytic squints and restrictive squints. Paralytic is when you see palsy of one muscle because of any of the ocular cranial nerves involved, that is third nerve, sixth nerve, or a fourth nerve, that is called as paralytic strabismus. Restrictive, the most common restrictive is because of the restriction of the extraocular muscle, you get a restrictive strabismus. The common ones being thyroid eye disease, blowout fracture, or the medial rectus entrapment following a surgery, or a fracture. All these causes a restrictive strabismus. There's one more, a few books give a classification as spastic strabismus, which is not commonly used. You have to remember these, paralytic and restrictive. And you should also know the difference between these two conditions, which is again a commonly asked question. Okay, let's see this 9 gaze picture. So what do you notice? First you focus on the middle picture. You see that the left eye shows a ptosis and an outward and a downward deviation. Okay, when the patient attempts to look up, you see there is an elevation limitation. And when the patient attempts to look down, there is a depression limitation in the left eye. And you see that the levo version is normal, that is left deviation is normal. When he tries to look to the right, you can see there is a small limitation of adduction. So what is this clinical condition? It is a third nerve palsy. So third nerve palsy is one of the incomitant deviation presenting with exotropia. So there's a lot of features which you have to remember in third cranial nerve palsy. I don't want to go into the details of third nerve palsy. So clinically, they present with ptosis, limitation of elevation, depression, and adduction, because these are the muscles which are involved. Except for lateral rectus, all other muscles are involved in third nerve palsy. There can be pupil involvement or pupil sparing. So this is quite an important point to remember for postgraduates. Pupil is commonly involved, then you call it as compressive any compressive condition like a tumor or an aneurysm can cause pupil involvement. Whereas in case of ischemic neuropathies, like in diabetes, you get a pupil sparing, and you should know the cause, why the pupil is spared and why the pupil is involved. So you have to know the underlying cause for that. So other commonly asked questions, I've just tried to explain you what is commonly asked in a third nerve palsy. So the other question is aberrant regeneration. Aberrant regeneration happens most commonly in case of any trauma involving the third nerve or any tumors or aneurysms. And it is very, very uncommon to see an aberrant regeneration in case of ischemic mononeuropathies. So you should remember aberrant regeneration and all the signs which are involved in aberrant regeneration. Aberrant regeneration is nothing but the nerve grows aberrantly, and instead of supplying one muscle, it supplies some other muscle. The nerve supplies the other muscle. So this is where you get a pseudography sign, which is nothing but there is retraction of upper lid on an attempted adduction. So that is called as pseudography sign. And also you see pupillary reaction or a light near dissociation happening, especially when the patient tries to move the eye. So extraocular motility will cause pupillary reaction. These are all few of the favorite questions which are asked in a third nerve palsy. So managing third nerve palsy, again, you should know that any mononeuropathy, the underlying systemic condition has to be addressed first, and you can wait for a spontaneous resolution of the condition, because any any nerve can have a spontaneous growth over a period of 3 to 4 months post the palsy. So wait for the spontaneous resolution, and you have to plan for surgery only in case of non-resolution after a period of 5 to 6 months. In case of third nerve palsy, you look for how much amount of the recovery has happened. Sometimes it stops with a partial recovery. In that case, you look for the medial rectus recovery. Sometimes medial rectus would have recovered, so patient will have good abduction and adduction, only elevation and depression is restricted. In that case, you can just go for recess resect procedure, or else you can go for a complete palsies, you go for a transposition. That is when you take the lateral rectus, split the lateral rectus into two and bring it and transpose it towards the medial rectus. That is one commonly done procedure for third nerve palsies. And the other commonly done is the lateral rectus deactivation. The only acting muscle in a third nerve palsy is the lateral rectus. You just deactivate, the eye comes to the primary position. So that is in short about third nerve palsy. Now let us look at this picture. So you can see the left eye is exotroping in the middle picture. So look, when the child looks towards left, you can see a small abduction limitation in the left eye. When the child looks towards right, you can see there is narrowing of palpebral aperture. So there is narrowing, and when the child tries to slightly attempt an adduction, you can see some upshoot happening. The eye is going up. In the first image, you can see the eye is, this is called as an upshoot. There is a narrowing of palpebral fissure and abduction limitation. This is one of the favorite of all the examiners and most commonly asked clinical condition, both in theory as well as in the practicals. So you should know in thorough this condition, which is nothing but the Duane's retraction syndrome. So Duane's retraction syndrome can present either with esotropia, orthophoria, or exotropia. So basically, you have to differentiate between a normal alternating exotropia and a Duane's. This can be done only by assessing the palpebral fissure changes, and otherwise you can get misguided. You can either diagnose it as a third nerve palsy or a sixth nerve palsy. All these are the differential diagnosis. You have to differentiate between a third nerve palsy and an exotropic Duane's. You can do this only by looking at the palpebral fissure changes. So never miss to look for palpebral fissure changes in an exam. So this exotropic Duane's, again, Duane's retraction syndrome belongs to a group called as congenital cranial disinnervation disorders. So basically, it is a type of restrictive strabismus which is causing limitation of movements. There are various theories. There is neurological theory, there is a muscular theory. You don't have to know in detail about those things, but you should know there is limitation of movement which is out of proportional to the ocular deviation in primary position. Basically, most of the time there will be limitation of either only abduction or only adduction or a combination of abduction as well as adduction. So it is a type of incomitant deviation and a with a restrictive pathology. Basically, the muscles are tight in an in a Duane's retraction syndrome. Clinical features, as I already told, there might be a limitation of abduction, adduction, or both. Always look for narrowing of palpebral aperture and upshoots, downshoots, and globe retraction. Go back and read about the causes for this upshoot and globe retraction, which is very important. Last but not the least, this is dissociated horizontal deviation. So there is an exodeviation. You're doing an alternate cover test. One of the eyes shows a slow isotonic drift. So that is called as dissociated horizontal deviation. Basically, one eye shows no movement, whereas the other eye is still showing a small amount of horizontal deviation. That is called as DHD, or dissociated horizontal deviation, which is again an associated condition with other. So DVD is nothing but dissociated vertical deviation. So that is more common, and usually it is associated with other congenital concomitant deviations. One point you have to remember about DVD or DHD is that it does not follow Herring's law. Herring's law is nothing but when some amount of impulse goes to one muscle in one eye, the same amount of impulse goes to the yoke muscle in the other eye. So it shows the deviation. But here, since it is dissociated, you see only one eye showing the deviation. That is why it is called as dissociated vertical deviation or a dissociated horizontal deviation. To conclude, always concentrate on taking a proper history, because history gives a clue towards diagnosis. Also do a proper systemic evaluation is most of the time is sufficient to come to a diagnosis. So any squint for that matter, always do a cycloplegic refraction, give a best corrective glasses. That will be the first step in management of any strabismus. If there is any amblyopia, treat the functional surgical results, stage and time the surgery. So maybe I can conclude my talk here. Thank you.
Thank you. That was really a wonderful and comprehensive talk. And for the students, we do have a lecture on third cranial nerve palsy, and that's CCDS. So that will be covered subsequently. Meanwhile, Gunjan, Dr. Anita, any questions by the students or any discussion points?
Thank you, Dr. Amrita. It was very comprehensive compilation of all the whole topic of exotropia, though it was very lengthy because you had to cover a lot of topics together. So it was
Yes,
a full presentation. Yes.
thank you.
For PGs, just a quick review. What are the main indication whenever IDS patient comes to you? How you decide to go for a surgical intervention? Though it is given in the classification for them whenever they are seeing patient, what is the easy answer they can give to the examiner? Like what are the indications of
Yeah.
squint
So that is,
surgery in
yeah.
IDS patients?
Yeah, that is a very commonly asked questions in exam. So you have to basically remember 5 points. One is the loss of binocular vision when the patient develops suppression in one eye. that is an indication for surgery. When there is loss of stereopsis, as I already mentioned, if once they start losing the distant stereopsis, that becomes an indication for surgery. Clinically, when you are evaluating, if you see a poor control intermittent exotropia, that is an indication for surgery. And of course, patient presenting with asthenopia or any diplopia, that becomes an indication. And lastly, for cosmetic, as well as when in case if it is a very large deviation, that is when we plan for a surgery in case of intermittent exotropia. Otherwise, we can always try to manage them through non-surgical methods until they reach that stage.
Yes, correct. And if any patient of IDS comes to them with a variable deviation, like parents gives a very variable history, so what should they do? And whenever they are doing examination, they are finding the very less amount of squint. So what is the perfect way of going for that patient? Yeah.
Yeah, if you actually examine any child fresh in the morning, you see the squint, almost no squint, the child will look orthophoric. So you should not get misguided with that. So as the day goes, you can see the deviation increasing. So that is when the child starts to lose the fusional reserves. That is when the manifestation of squint happens. So always do a proper prism cover test or an alternate cover test. Try to bring out the maximum amount of deviation. As I told, two important tests which are done to get the maximum amount of deviation in intermittent exotropia is one is the prolonged monocular patching. So patch either of the eye for 30 to 45 minutes, then do a prism cover test. That gives the maximum amount of deviation. Or you can do a far distance measurement, like place the patient at a long hallway and try to make them fixate at a very long distance and do a prism cover test. That also gives a maximum amount of deviation.
Yes. Actually, this is very important before planning for the surgery. And most importantly, after patching, half an hour patching, they should not uncover both the eyes together and
Yes,
test.
yes,
So this is also
yes.
important. They should know because in exam they ask how you will do it, and
Yeah.
this is a very common mistake they do. So
Yeah,
that
that
is
is why I
also very
wanted to
important.
show it through a video. I think I
Yes.
demonstrated that in a video.
Yeah. One last question, Dr. Amrita. Like in sensory exotropia, whenever the patient is not having vision because of some reason, so what is the good time to go for surgical intervention in such patient? Because sometimes patient is presenting to you early when
Yes.
they have the sensory component, but the deviation is not that large. So what is the criteria? What is the
Yeah.
indication of
So we
surgery?
should always keep in mind we are doing this sensory correction only for the cosmetic purpose, but you should also keep in mind there is a chance of recurrence in these conditions because the eye which doesn't have a vision can always cannot maintain orthophoria for a long time, so it can drift. So most commonly it goes for an exotropia over age. So ideally better not to operate for sensory deviations at a very early age, because once you're done, you have only one chance, one shot to do the surgery here. One eye can only be operated, and doing a resurgery at a later age when the child becomes older and develops a recurrence again is very difficult to operate on an already operated eye. So it would be ideal to do the surgery at a later age. Probably I would say about 12 or 15 years of age will be an ideal age to correct the sensory deviations.
Hello,
Yes.
Dr. Amrita.
Yeah.
Hi,
Uh,
Dr. Gunjan.
Yeah, Gunjan would like to. Last thing I want to add here, yes, I also decide like if the deviation is significant in sensory exo, at least more than 25 prism diopter when it is actually affecting their personality also. And second, as you rightly said, the age, because for younger children, it's not necessary to go for the cosmetic correction because that is only the cosmetic. So always tell the patient for the recurrences, and yes, well explained surgical intervention always would be better. Gunjan,
Yes.
yes, please ask. Sorry.
Sorry. Sorry to interrupt. Actually, I wanted to ask about the angle kappa and the importance of pseudo exotropia, because that is also a very commonly asked question in the postgraduate exams.
Yeah, so angle kappa is, as we know, it's an apparent squint. It's not a true deviation. Eye seems to be deviated outwards, but when you shine a torch like a Hirschberg test, you see the it is almost orthophoric, and when you do a cover test, there is no deviation. So eyes are just fixed in that exotropic position. So that is because there is a difference between the visual axis and the pupillary axis. The angle between these two lines is called as angle kappa. So when it is positive, it gives a pseudo exotropia. When it is negative, it gives a pseudo esotropia. So it can also be seen in case of wider pupillary, increased interpupillary distance. So this also is important to know this angle kappa in case of not only squint, but also in case of planning for an IOL surgery, or even during a refractive surgery, this angle kappa plays a role.
And then you mentioned about Newcastle scoring for exotropia. There are certain other scoring systems also which are used for deciding the surgery, like lactose scoring system.
Yeah, I went through. I don't exactly remember the classification, but there are few more classification. There is also a modified Newcastle scoring system, and I think it's better to know about these the other scoring system as well.
So that they should go back and read. Then there is something called lateral incomitance. While we are measuring the deviations for exotropia, we do not want lateral incomitance in the post-op period. So if you can add on that.
Lateral incomitance, I'm not very sure. Can you explain about that?
Yes, so basically we have to take deviations in all the gazes, especially the lateral gazes, and because sometimes surgery is planned like bilateral lateral rectus recession in these cases. So that can induce a lateral incomitance in the post-op period. That has to be kept in mind while they are seeing the patient and answering also. Sometimes they do ask about lateral incomitance in their patients, especially if the examiner is of a squint specialty. Then you mentioned about the deterioration of distance stereopsis. If there is deterioration in the distance stereopsis, then the patient should undergo surgery. So how much should be the deterioration, and what is the normal value for FD2 test? If we are
normal stereopsis is around 60 seconds of arc. Anything less than that, I would say 120 or 240, anything like that. Usually we will think of planning for
the distance stereopsis, I think. Yes, so they should know about the distance stereopsis normal values, which are around 20 to 40.
Yes.
And then the role of sometimes prisms are also asked regarding this, because if the patients also demand sometimes. So what is the role of prisms, and how much prism maximum can we give?
The role of prism, we don't give prism in regular clinical practice. When the angle is very small and it is very variable, that is when we can think of giving a small amount of prism just to improve their fusional reserve. So in a glass, normal spectacles, a glass mounted prism up to around 8 in each eye can be given easily. So that is the amount which we can give as a glass prisms. Whereas if you go for Fresnel prisms, you can give up to 20, although it's not really accepted up to 20 or 25. You can easily give up to 14 or 16 prisms by using a Fresnel prisms.
Yes, and then it can also be given in the post-op period when patients do have exodrift at 1 month. So that is also to be kept in mind. And even if someone is asking them about planning of the surgery, that also has to be kept, that they have to overcorrect up till 8 years of age, and after 8 years they have to they have to undercorrect up to 8 years of age.
8 years of age. So the success of surgery, we would say, is either orthophoria or a small amount of esophoria. Because if we leave small amount of exodeviation, that tends to drift over years. So it will lead to a recurrence. So it's always better to slightly overcorrect, especially when the child is very young.
Actually, if the child is more than 8 years, we tend to overcorrect, so that it can compensate for the exodrift. And if the child is less than 8 years, then better to slightly undercorrect, because we don't want amblyopia because of esotropia.
Yes, right, you're right. Yes.
So that is what has to be kept in mind. And I think we have covered almost everything. Very nicely, nice presentation. Thank you. Do we have any other questions, Anita ma'am?
Yeah, I think in the chat, the question has been posted by one of the postgraduate. How common is dissociated horizontal deviation and DVT? Is it very subtle to miss in the OPD? Shivam Goel, Dr. Shivam Goel has raised this question.
Yeah, as I already mentioned, dissociated vertical deviation is quite common and it can be easily picked up. So when you're doing a cover test, so alternate cover test, you can see that one of the eye just slowly gives a slow downward drift. It won't be a sudden drift like you see in a vertical deviation. So it will be a slow downward drift of one of the eye. It can be easily picked up, and you can also grade the dissociated vertical deviation using a neutral density filters. But DHT, as I already told, it is not that common, although we do see them associated with but it isolated DVD or DHT is less common. Usually it is associated with other concomitant deviations like a congenital esotropia or an exotropias. So it is usually seen as an associated condition.
And sometimes they confuse it with the Heman-Belchowski phenomena also. So do you want to add something, Amrita, Dr. Amrita?
Maybe you can explain that.
Yeah, so basically in patients who are having sensory squints, you can also observe a movement, a small
bobbing movement.
Yeah, bobbing movement or a small drifting movement the eye coming from up to down when you uncover. So that is Heman-Belchowski phenomena, and that also should be kept in mind.
And so one more question, ma'am. If there's a patient who has refractive error and wants to go for refractive surgery and has IDS, so in such patients, what is the line of management that should be advised to these patients?
So in such cases, you should always explain the patient that they have an intermittent squint seen, and there is a slight possibility that the squint might increase post-refractive surgery. So you can always give an alert before planning for a refractive surgery, because some amount of prismatic effect will help them to keep their fusional reserves well with glasses. Once you make them very much glass free, there is a very slight chance that the IXT might worsen. So in that case, they might require an additional squint procedure. It is always better to explain them prior to starting on any refractive procedure. So, and regarding which surgery to be done, again, I think many people have a difference of opinion. Either if it is a very large intermittent exotropia, you can do a squint surgery and then go for a refractive surgery, or it can be done either ways also.
Very important question and very controversial, actually.
Yes, it's a controversial.
Yeah, so it's depending upon surgeon's preference most of the time. But I think if the IDS is very poor fusional reserves and it is deviating very frequently, so well explained to the patient, or you can go for squint surgery also first prior to this thing.
Yes.
But yes, as you rightly said, explain to the patient, and it's better. In very small deviations, this can happen that it increases after refractive surgery. So they are so motivated, they already understand very well that yes, we will go for the squint surgery also later on.
Yes.
So only explanation should be there. Yeah.
Yes.
I think with that, we'll come to an end of the class. Professor, would you like to say anything?
Yes, I would like to say a few words to the students. Now, don't think that all this discussion that these experts are doing are going to be asked to you. So don't panic. You know, the questions will be basic, squint workup, all this thing will be asked initially. Once you are okay with that, then the examiner will pass you surely. All these questions like what Dr. Gunjan and later on discussion was going on, like refractive surgery, these points you should know, because if you answer these questions, you will score exceptionally well. But don't get scared by such type of discussion that you don't know anything. Try to revise. Squint is a very difficult topic. Now, once you read it again and again and watch videos, all these videos are there in our website, right? So if you watch it again and again, then you will get the concept of squint on all these discussion points. Am I right, Gunjan?
Yeah. Yes,
Sir,
sir.
I would like to
Definitely.
add here, yes, these are not to be asked in the exam, but yes, I think sometimes we hear something clinically related, so it stays with us
No,
somehow.
these
So
questions can be
maybe
asked. See,
yes,
when if somebody is answering very
very
nicely,
nicely, then the
then the
next question
examiner has a
could be
Yes.
tendency
easier.
to ask this question. So
Yeah,
my suggestion to students is first cover the basics,
Basic
and
things.
also you should
Yes.
know all these things also. It's not that you should not be completely unaware.
these are
And
the
anyway,
bonus
for
questions.
fellowship exam, SRCP exam, also these questions are asked.
Yeah. So I think that is all.
This is a
We
small appreciation, Dr. Amrita from DOS.
Thank you, sir. Yes.
And if you join us, and would like to welcome you to our winter DOS, which we are going to do it in 11th, 12th October, and our annual DOS will be in April next year.
Okay.
So if you
Yes.
join us, we'll be happy to hand over this frame certificate to you.
Sure, sir. I'll
And
try.
thank you again.
Yes.
And good
Thank you,
night,
sir.
all. Nice
Thank
discussion
you.
by all the moderator.